Hello, welcome to Pathagonia. This is Jay. Today we're going to talk about the difference between paraganglioma pheochromocytoma versus a neuroendocrine tumor using a case. So, a patient with MEN1, which is an autosomal dominant inactivating mutation of tumor suppressor gene MEN1 on chromosome 11, where you have increased risk of pancreatic neuroendocrine tumor, parathyroid neoplasia, and pituitary tumors. There is spinal mass that was noted, and a biopsy was undertaken. There was a 0.4 by 0.2 centimeter specimen received, and between the intertrabecular bone, there is a group of cells that have granular chromatin, some anisonucleosis. A workup was done, including INSM1, which was nuclear positivity, and S100, although faint, you can appreciate some positivity in these cells interspersed. AE1, AE3, or pancytokeratin, was negative, and GATA3 was positive. So the diagnosis was metastatic paraganglioma. Remember that paragangliomas are non-epithelial neoplasms derived from chromaffin cells of the paraganglia in the autonomic nervous system. You can have sustentacular cells that are S100 positive. There is confusion with neuroendocrine tumors that are neuroepithelial derived, and hence they are cytokeratin positive. Both can have nested architecture, expression of neuroendocrine markers, as we saw with INSM1, and somewhat similar cytology. So the next step done was a dotatate scan. And dotatate scan uses gallium-68 dotatate, and this binds to somatostatin receptors that are highly expressed in neuroendocrine tumors, and in the past used to be octreotide. Findings found a neck avid lesion, as well as a small increase in the uncinate lesion in pancreas, and a 1.1 centimeter uptake in the right liver. An excision was done of the right neck, and from low power we can see a cellular, vaguely nested architecture of cells. On closer look, you have some pleomorphism of the cells, some intranuclear cytoplasmic inclusions as well, and inkies, with, in addition to a nested architecture, a little bit of trabecular architecture. INSM1 was positive, like the prior vertebral case. GATA3 was positive. AE1, AE3 was negative. CAM5.2, which is a low molecular weight cytokeratin, and my staff uses this to help avoid false negative results in the workup of some neuroendocrine tumors. And S100 showed some positivity as well, and so the diagnosis was compatible with paraganglioma. We did additional testing, that is SDHB testing, because mutations in SDHB are associated with an aggressive course of pheochromocytoma and paraganglioma. Then, an excision of the right liver was taken. It was 3.2 grams and 1.5 by 1.6 by 3.2 centimeters with a 1.4 centimeter stellate white lesion grossly visible. So here we have more of a discernible nested architecture with a little bit of trabecular architecture, and there is a more prominent amphiphilic cytoplasm as well as salt and pepper chromatin. It's hard to see from here, but INSM1 was positive. CAM5.2, this is just a low molecular weight cytokeratin, was positive. AE1, AE3 was positive. MOC31, another cytokeratin marker, was positive. GATA3 was negative. S100 was negative. And PAX8 was done, and it was positive. And PAX8 helps distinguish pancreatic well-differentiated neuroendocrine tumors from other well-differentiated neuroendocrine tumors, suggesting that this tumor is originated from the pancreas and metastasized to the liver. So the learning points in this case are paragangliomas pheochromocytomas can look similar histologically to neuroendocrine tumors. They can share similar IHCs like INSM1 and other neuroendocrine markers, and both be dotatate avid. Just remember, for neuroendocrine tumors, it is cytokeratin positive, and paragangliomas pheochromocytomas, cytokeratin is negative, GATA3 is positive, and S100 should be positive for sustentacular cells. Thank you so much for listening, and we'll catch you on our next episode of Pathagonia.